So here this actually says, so what is actually important in burn management is the fluid and electrolyte correction. So you have to that is calculation of the fluid electrolyte loss is based on this rule of 9, and in adults and in individuals below 15 years, it is calculated on the basis of Lund-Browder chart. Okay, so that is to just emphasize that part. Okay, then when we here we are talking about skin grafting. So there are two types of skin grafting. So one is known as split thickness graft, and the other one is the full thickness graft. So the other names of split thickness graft and full thickness graft are given here. But what we need to understand is the differences between the split thickness graft and a full thickness graft. So the main important difference is the fact that split thickness graft is involving the entire epidermis and only a portion, upper layer of the dermis, whereas the full thickness graft involves the entire epidermis with the entire dermis. And there are many other differences between the split thickness graft and the full thickness graft as to what are the indications for the split thickness graft and what are the indications for full thickness graft, and how do you actually extract the split thickness graft, that is using a Humbee's knife or dermatome. Whereas for the full thickness graft you use scalpel or scissors. And what are the donor sites for split thickness skin grafter and for the full thickness skin grafter? So it is different. The donor sites for two are different, and there are many other differences as to how the recipient area is going to take it up easily regarding the color change, hair growth, and these are other differences that needs to be known. But importantly, what you have to know is what, how split thickness graft are exactly, and what does full thickness graft means. Okay, at its basics. Then you can see, especially full thickness grafts are used for the facial surgeries. Okay, facial surgeries is wherein you use this full thickness graft, and there is one more entity called as composite skin graft, and this is used in case of three-dimensional reconstruction, such as that of nose, where you will be using two kinds of tissue. That is, in addition to skin, you will be making use of cartilage for grafting. Okay, and that was all about allografts. Next, coming on to the autograft. Next, coming on to the allograft. So allograft is from a different individual, a donor individual. So here you are talking about cornea. The first entity is a corneal transplantation. So that is collected from a cadaver. And what is an advantage here with the corneal grafting is the fact that there is no risk of graft rejection that is seen with the cornea, because cornea is avascular. And why is that important? Because graft rejection is this entity which is occurring because of the antigenic incompatibility between the donor tissue and the recipient. Okay, because the genes in the donor is going to code for certain antigens which are different from the antigens that are coded by the recipient's genes. So when you're going to actually transplant the donor's tissue, what the recipient's immune system thinks is that whatever the antigens are expressed on the donor organ or tissue is foreign, and it will elicit or mount an immune response against it, and it is going to destroy that tissue. And this is mediated by none other than our lymphocytes, that too the T lymphocyte, the CD4 and the CD8 cells. Okay, so and where are these lymphocytes located? They're located in the blood. So where the blood is nothing but they are in the blood vessel. So since cornea is avascular, it is not having any blood vessels, so it is not having the lymphocytes at all. So the risk of graft rejection is not seen with the corneal transplantation. And so if that is the case, where does the cornea receive its nutrition from? It receives the nutrition from the aqueous humor and the tears. So from the outer surface it's the tears, and from the inner surface it's this aqueous humor which is there in the anterior chamber. And these are nothing but some additional information as to what are the layers that are there in the cornea. So it has got these 5 layers, and there's an additional layer, the 6th layer, that has been found out, and to everybody's honor in India. So it is actually found out by an Indian only, and that layer is known as Dua's layer or Dua's membrane, which is the 6th layer that's found in the cornea in addition to these 5 layers. Okay, now that was all about the corneal transplantation. So you can see this was the old cornea that's removed, and this is the new corneal transplant that has been stitched at this site. Okay. Yes. I actually did forget about this terminology, that is supravital period. What is a supravital period? That is important when transplant is collected, or graft or tissue is collected from the cadaver. So when a person dies, all the organ systems will stop functioning first, and that is referred to as a somatic death. And about 2 to 3 hours after the somatic death, the individual cells are going to die, and that death of the individual cell is referred to as molecular death. And this time interval of 2 to 3 hours between the somatic death and the molecular death is referred to as supravital period. And it is during this supravital period that the organs for transplantation are harvested. Okay, and yeah, that's about supravital period. And then talking about other allografts, so kidney transplantation, liver transplantation, heart transplantation. So in liver transplantation, I did mention about coinoid segments. And yeah, kidney transplantation. Generally, if you have to collect it from a living individual, which kidney are you going to prefer? So some might say it is right and some might say it is left. Now that is not the criteria for actually saying which kidney has to be left behind in the donor and which kidney has to be actually collected for transplantation. So now that is based on this known as GFR, that is glomerular filtration rate. So which kidney has got higher glomerular filtration rate, that will be preserved or that will be left behind in the donor, and the other kidney of which the GFR is less is going to be taken for